Hello, everyone. You are welcome to my YouTube channel. The topic of discussion is neonatal tetanus, which is the second childhood disease to be discussed. In a previous video, diphtheria is a childhood disease which was fully discussed. Now, for today, I'll be discussing neonatal tetanus. What is neonatal tetanus? A case of neonatal tetanus is simply a case of tetanus of the newborn. The newborn is referred to as neonate. Let's look at the etiology or the causative agent of neonatal tetanus. Tetanus is an acute, often fatal disease caused by a potent exotoxin, tetanospermine, which is produced by a bacterium known as Clostridium tetani. The newly cut umbilical cord of a newborn can be a pathway for neonatal tetanus and death when it is contaminated with spores of Clostridium tetani. When the umbilical cord storm becomes devitalized, it provides anaerobic conditions required for the germination of the spores of the bacterium Clostridium tetani. Let's look at the characteristics of Clostridium tetani. Clostridium tetani is a gram-positive bacterium with terminal spores looking more like cells with drumstick appearance, and it is an anaerobic rod. What do I mean by that? It means the organism cannot survive in the presence of oxygen. It requires complete absence of oxygen in order to grow and for the spores to germinate and produce this powerful or potent neurotoxin. The spores of Clostridium tetani are widely distributed in the soil, in the intestine and feces of farm animals such as horses, cattle, and chickens. Also, the manure-treated soil contains very large numbers of spores of Clostridium tetani. Clostridium tetani is known to produce two exotoxins, one tetanospermine and tetanolysin. Tetanospermine is a neurotoxin, that is, it affects the nerves and causes the clinical manifestations of tetanus. Tetanospermine is one of the most potent toxins known, with the estimated minimum human lethal dose as 2.5 nanograms per kilogram of body weight. Here is a picture or a plate showing the spore-bearing cells of Clostridium tetani with the drumstick appearance. Here is the terminal spore. Next, we'll look at the pathogenesis of tetanus. That is the process establishing the disease tetanus. Like I said earlier, if the umbilical cord stop is not properly cleaned, it becomes devitalized. It is actually a wound and it must be kept clean. But if it is contaminated with spores of Clostridium tetani and anaerobic conditions are provided by this devitalized wound, this will enable the germination of the spores of Clostridium tetani and production and release of the neurotoxin tetanospermin. Early in the course of the disease, tetanospermin is known to cause tension or cramping and twisting in skeletal muscles surrounding the wound, and also tightness of the jaw or masseter muscles. Tetanospermin is a non-endopeptidase which selectively cleaves the synaptic vessel membrane protein synaptobrevin. This inhibits exocytosis and release of inhibitory neurotransmitters at synapses within the spinal cord motor nerves, leading to uncontrolled stimulation of skeletal muscles. As the disease progresses, there is trismus, that is lockjaw, an inability to open the mouth because of the spasm of the masseter muscles. This progresses to the spasm of the facial muscles, leading to a condition known as rhizus sardonicus. It progresses further with the contractions and spasms of the trunk and extremity muscles, which may be so severe that there is bud-like rigidity, just as if it is a piece of wood when touched. There are also painful tonic convulsions and opisthotonus, which is the backward bowing of the back so that the heels and the back approach each other. Spasms of the diaphragm and intercostal respiratory muscles lead to death. Here is a flowchart of the pathogenesis of neonatal tetanus. In summary, spores of Clostridium tetani contaminate the vitalized tissue of the improperly cleaned umbilical cord stump. The anaerobic conditions provided by the devitalized umbilical cord stump allows the production and release of neurotoxin tetanospermin. This tetanospermin then inhibits the release of neurotransmitters, and this leads to uncontrolled stimulation of skeletal muscles. There is trismus, lockjaw, that is, the jaw is locked. The spasm of masseter muscles leads to the locking of the jaw, and the patient is not able to open his or her mouth. This proceeds further to spasm of the facial muscles, leading to the rhizus sardonicus, and then opisthotonus, which is the backward bound of the back so that the heels and back approach each other. Briefly look at the epidemiology of neonatal tetanus. Any break in the skin, such as the wound, which is the umbilical stump, can allow Clostridium tetani endospores to germinate if the oxygen tension is low enough. The problem we have in the rural settings in developing countries is the use of non-sterile techniques in umbilical stump care, which is the major disposing risk factor to neonatal tetanus. Harmful traditional cord care practices, such as the application of cow dung to the umbilical stump, ashes, uncooked cocoyam with salt and water, as well as the application of clarified butter known as ghee, predisposes the neonate to neonatal tetanus. In-use contamination of ghee, the clarified butter prepared from the fat of buffalo, is a risk factor to newborns contracting neonatal tetanus. Other materials which may be contaminated with spores of Clostridium tetani and when applied to the umbilical stump include the following: engine or motor oil, charcoal, crush, wax net, palm oil, burnt pumpkin skin, python oil, dirt from a pestle, native chalk. Other substances include boric acid powder, mustard oil, petroleum jelly, toothpaste, methyl containing balm, turmeric powder, ash from burnt papyrus, sandalwood powder, ground seal shell, and even dried chicken droppings may be applied to the umbilical stump. In rural settings and even in urban settings where pregnant women are delivered by traditional birth attendants. However, WHO recommends the use of daily application of chlorhexidine to the umbilical cord stump during the first week of life for newborns delivered at home. Let's look at the clinical presentations of neonatal tetanus. The incubation period is usually 8 days, but may be up to 21 days. There are 3 clinical presentations of tetanus. You have the generalized neonatal tetanus, which is the most common, the local tetanus, and cephalic, which is rare. The generalized tetanus is characterized by tremors, which is lockjaw, stiffness of the neck, dysphagia, difficulty in swallowing, rigidity of abdominal muscles resulting in obstructonus. Other symptoms include pyrexia, sweating, increased blood pressure, and cardiac arrhythmia. Neonatal tetanus is a type of generalized tetanus which occurs in newborn babies. Neonatal tetanus is characterized mainly with inability to suck, increased irritability, trismus, lockjaw, opisthotonus, and bud-like rigidity of trunk muscles. Neonatal tetanus occurs in the newborn without protective passive immunity from the mother. It occurs when the umbilical cord is cut with an unsterile instrument, leading to contamination of the unhealed umbilical stump with spores of Clostridium tetani. Here is a picture of a child with trismus and rhesus pseudonicus. The spasm of the facial muscles, which is rhesus pseudonicus, and trismus, that is, the jaw is locked or is locked. There is another picture showing a child with opisthotonus, with the back bending towards the heels. Diagnosis of neonatal tetanus. The diagnosis of tetanus is entirely clinical and does not depend upon bacteriological confirmation. Management of neonatal tetanus. The umbilical stone should be cleaned with WHO-approved antiseptics, such as chlorhexidine. Necrotic tissue and foreign material should be removed. If tetanic spasms occur, supportive therapy and maintenance of an adequate airway are required. The WHO recommended schedule for tetanus toxoid containing vaccine, that is TTCB, includes 6 doses, a 3-dose primary infant series and 3 booster doses given at ages 12 to 23 months, 4 to 7 years, and 9 to 15 years. How can neonatal tetanus be prevented and controlled? Women of childbearing age should be immunized with tetanus toxoid. Maternal immunization is recommended with 2 doses of tetanus toxoid 4 weeks apart during pregnancy to prevent neonatal tetanus. It is advisable that women within their childbearing age should get not less than 5 total doses of the tetanus toxoid vaccine in line with the expanded program of immunization schedule. Clean cord care is one of the essential newborn care practices recommended by the World Health Organization. Training of traditional, training of traditional birth attendants and providing them with disposable delivery kits. Also, the WHO, here are some links for further reading. Thank you for listening.